welcome to the May Community Brunch. Actually, it's the Brunch and Learn. And for those of you who might not know me, I am Linda Maupin, excuse me, from the Family Support Center. And Wednesday mornings, since COVID, are typically the Fresh Food Initiative, and we normally have a lot of people in our parking lot. So we were looking for an alternate time. As you can see, Wednesday lunchtime is kind of tough. We normally have about double this many people when we're in person. So we're excited to be in person, but we're really looking forward to hearing your feedback. And you'll notice on your tables there is a form, and we would like you to fill that out and leave it for us after this meeting. I'd like to thank the following agencies who represent the Planning Committee and who organized today's Brunch and Learn: Barry County Courts, Michigan Department of Health and Human Services, especially foster care, the Great Start Collaborative, CASA, and the Family Support Center. Today we're going to hear about a great topic, the Barry County Health Needs Assessment. We have two speakers today. Christopher Chesla-Hughes is currently the health analyst for the Barry-Eaton District Health Department, and he received his Master's of Public Health from the George Washington University with an emphasis on health policy. He's the lead coordinator for the Barry County Health Needs Assessment and Community Health Improvement Process. Chris has two young children and is excited to finally start traveling around the state with them this summer. And I know we would have a lot of suggestions for you in this room, so feel free to ask. Our second speaker is Emily Smale, who currently serves as a communications specialist and public information officer for the Barry-Eaton District Health Department. Emily earned her Master of Public Health degree from the University of Michigan. She specialized in health behavior and health education with a focus on population health. At the Barry-Eaton District Health Department, Emily is involved in many projects, including the Barry County Health Assessment and Improvement Process. She is passionate about health equity, women's health, and ways for everyone in the community to achieve healthy lifestyles. Emily is a resident in Hastings and enjoys the beautiful lakes and trails that Barry County has to offer, and we really do. So please welcome Chris and Emily.
So before I jump in, I do want to thank everybody who's helped us with this project. I do see a few faces around here who have been part of our calls, so thank you for being part of those and getting your input. But specifically, I'd like to call out Spectrum Health Clinic. I see our representatives here. Unfortunately, I don't see Janine, who's also been helpful throughout all of this. From the very beginning stages, this has been a good partnership between us, and we are thankful for all the help we got from you. And then on a personal level, on our side, Emily, been a tremendous help. She's been throughout the whole process, getting everything together, reaching out to folks, coordinating as I needed help, and really I could not have done this without her, so thank you to everybody there. So just to kind of level set on what really the assessment is and where it comes from. So back in 2010 with the passage of the Affordable Care Act, there were some IRS requirements that were set forth in that for hospitals to maintain their nonprofit status. So about once every 3 years we need to conduct a needs assessment, and that is kind of what we're doing here. And that does overlap at the same time with accreditation standards from the state and from the Public Health Accreditation Board, or FAB, for the health departments. And so in about 2010, 2012, it made sense to kind of partner up and do some of that work together so that these aren't happening in silos. We have all different strengths that we can bring to the table. And so it kind of evolved from there, and we've done I think this is our fourth cycle in Barry County, and then for our health department at Eaton County, we're also on our fourth cycle as well. So in previous publications, so this has been a little bit different, and I'll talk about that again in a minute. But in the past, the process has been largely driven by Spectrum. They had used consultants and specific people to conduct most of the process. Barry-Eaton was involved in specific instances of getting community input and organizing around that. But it was largely driven by consultants, and those publications came through that way. And that is one of the main differences that I'll get to in just a minute. But these are the publications that have come through. So you can kind of see that they are kind of spaced out a little bit different. And some of that is because Spectrum, as a large health system, was trying to align all of their projects to be at the same time so that they don't have to worry on different years who's sending what, when is that coming through. They can have one big picture about when they want those things to be. And so that gives a little bit of the weird timeline in there. 2022, the publication of the report is still pending. I received a draft of it, so the agreement we have in place is that Spectrum drafted the document. They provided it to us to kind of edit and alternate as we see fit so we can provide a public document. Theirs has to go through a lot more approval process from various boards and all the corporate stuff that takes time. So we weren't going to see publication for that for quite a while, unfortunately. So they were kind enough to send us the report in advance that we can use, and so we're going to work on getting that, hopefully in the next month or two, out to the public. A little bit of kind of like a definition setting. So we look at a community health needs assessment, and I'm going to use community health assessment, community health needs assessment kind of interchangeably. They're the same thing. The CHA, the CHA, is what we use on the health department side. The needs assessment is what they call it on the IRS, the hospital side. It's the same thing. So don't think it's anything different. But it is a systematic process that involves the community members, and specifically to identify, analyze the things that they need in the community, the assets that are available, and then help determine priorities based on the data that we see. And not just the data we see, but conducting interviews, going out into the public, getting that lived experience information, that makes it more relatable, folks. Instead of just pulling data from a database that may be a couple years old, we can see and really engage with people and say, what is going on now that we need to look at. And there are two major components to this. So the first is the assessment. That's the data portion where we're just kind of looking at what the landscape looks like. And then the second is identifying those health priorities. So after we've gathered, after we've analyzed and provided the data to the population to look at and get feedback to, we meet again to prioritize those things that we think are most important. And then after that, we'll feed into our health improvement cycle or our CHIP cycle. So I sort of mentioned this earlier, but these are the differences that I had mentioned, just kind of this cycle versus last cycle, just the consultant versus us doing it now. So I won't linger too long on that. Our model for kind of how we pull the data and how we bucket the data is based on county health rankings. So they just look at all the different levels that you can have influence on health. So from policies and programs, different health factors, to direct health outcomes, the ones we're used to, like morbidity, mortality, disease, and death, those sorts of things. They, on county health rankings, have about 30 different measures or so. And I think an important note here is that they just recently published a data update that is not reflected in what we see here. So there are some differences this cycle if you're going to go to their website and see what's there. It's going to look different than what you see here just because we pulled this prior to the change in the new year and got that into the document. One of the challenges of just having an assessment like this. So this is kind of like the feedback loop, or what I would call the feedback loop of the CHA and CHIP cycle. So, to start somewhere, we look at the assessment, so we pull that data, and then we analyze it, like I mentioned, talk to the community, engage the community, get their input, choose our priorities, then we feed into the CHIP cycle, which is where we're going to start very soon. The first thing we want to do is identify our community goals and objectives. So similar to how we brought the community together during the CHA process, we will do the same for the CHIP. So we'll start reaching out to folks and groups to be on these calls and these meetings to get information about what they feel like we need their goals and objectives to be related to the priorities we had previously chosen. From that, we'll choose specific measures that we want to look at. We're going to want those to be what we call SMART goals. So those, I'm going to blank on it, but very defined goals, specific, measurable, achievable, time-bound, but so specific goals that we can say we're making improvement on. We're not going to, like at the health department, we don't necessarily want to dictate to the community what we want to happen. We can say, we think this would be a good idea, but ultimately it's going to be you guys who choose what you're doing, how you're going to do it, and we want to help in that process to make those linkages where we can and improve, what is available to us. And then accountability is just kind of checking in after we establish those things. So once we get the CHIP off the ground, we largely let the community do what they want to do and implement those programs that they see fit. But we also want to keep people accountable and keep them on what they say they're going to do. So we will be looking for, input on like how often we should meet, what we need to discuss, those sorts of things. So it really is kind of an interactive, cooperative experience for the CHIP. And that will last about 2 full years. So we do this about once every 3 years for FAB purposes. For us, it's once every 5 years, but we tend to stick to 3 years for the hospital cycle so that they don't get angry at us and want to be partners So a lot of work has gone into this so far, and this is just kind of makes it look like not a lot, but there's a lot in each single step that took time, took effort. So this is really what we've looked at so far. We pulled data for 41 different indicators, so specific measures that we want to look at. There's time and point in time. There's race ethnicity data. There's income data based on income, and we also included all of our behavioral risk factors indicators. So Barry-Eaton does our own behavioral risk factor survey, which gives us some really great information. So this is on a 3-year cycle as well, and we're coming up on our 2022 cycle. So this is based on last cycle, but it's great because sometimes it's hard to get in smaller populations and areas that really define data that we can get with this survey that would be harder for the state to get. So like we can request the state do it, but it wouldn't be ongoing. We wouldn't have trend data. We wouldn't have those sorts of things available to us. Whereas with this, it's a great tool that gives us some really important information that we may not otherwise have. Beyond that, we also did our qualitative data. So usually we do these as focus groups. Largely due to COVID, nobody really wanted to talk to the health department during this time. And not just on, it's kind of an overall thing. I think people were kind of burned out. They didn't really want to be talking to people, doing different things. We offered virtual options. We ended up doing some interviews, and that's really where Emily stepped up and helped us big time. And she was able to come over here, I think, into the United Way office and sit down with folks and do one-on-one interviews as a way to get that information that we may have missed out on if we weren't able to do it that way. So that ended up being a real big help. We are also able to convene what we call a key stakeholder group, where kind of the leadership of the county to come together and discuss similar issues. So kind of same question set and get just kind of those two different perspectives on what's going on in the county to give us that full picture. Other avenues for community input. So we also had 3 advisory committee meetings. So these are essentially community stakeholders. They're groups, they're individual people. They can come to our meetings, hear about what's going on, have suggestions about what we should be doing. And one of those is where we share the data, prioritization, those are the sorts of things we discussed at these meetings. We also did a community survey and a healthcare provider survey. So the kind folks at Spectrum were able to host these surveys for us through some of their survey software. And we had some great information from that, which we'll share later on. And then again, specific to healthcare providers, also getting their perspective on what is going on in the county, what services they refer to, what kind of services they think they need. All valuable information be part of the assessment.
Chris,
Yes.
I'm sorry, who did you say did the survey data?
The survey data, the survey was, Barry-Eaton drafted the survey with input from Spectrum and Spectrum Panic, and then they hosted it on their survey software, and then we all worked together to kind of disseminate it throughout the community to make sure that we can get it as many places as possible.
Gotcha, thank you.
Another thing we do is asset mapping, so that is kind of categorizing and looking at the different resources and assets we have in the community that can positively impact people, whether it's health, whether it's economic. Those are the things kind of we looked at. So initially we had looked at some things, and in the end, the group chose to look at something we haven't worked on before, which is economic resources, which is pretty cool. So it was nice to dive into a little bit of a different area than we had previously. And I will talk a little bit more about that in a bit. But here I would like to thank Barry County GIS. They helped us map all the different individual things that were involved with it. In terms of outreach, email addresses and like blast emails, Facebook, social media, coalition outreaches, those sorts of things were really helpful getting the word out. Publication of the document I mentioned, this should be coming soon, and prioritization we've done. Our timeline for what we've done, so we kicked this off over a year ago now, so January, February, when we were looking at our first initial meetings between ourselves, between Spectrum, to kind of figure out what we wanted to do and how we wanted our partnership to look like this time. We kicked off with the community around March, so that was our initial one where we said, these are the indicators we'd like to look at. How do you guys feel about this? They got approved, we moved on, we collected the data. Came back a little bit later, said this is what we found so far. Also, what kind of things we'd like to do with the asset mapping, so that's where the conversation was had about what we want to focus on, what we want to find in the community. And again, a little bit more than that in a bit. Our data preview was another one. So this is after we had gathered all the data, we kind of bring it to everybody to get their initial reaction to what is going on in the community based on the data we can find. And then get input, is there, ask the question, is there anything we missed? Do we feel like there's anything else that should be here? Should we remove something? And this time, which doesn't happen very often, we did actually have some things that were added, which was great, because folks felt there was a need for those extra things to be there. And then prioritization and publication, and then starting our chip soon. Just to recap, so these are kind of what we tried to look for, where they were available. So we had about 41 total things we looked at. And then again, where available, we looked for specific points in time, so your yearly data, trends, if we've been doing it for a few years, breakouts by age, by income level, by gender, education, race and ethnicity, all where we can. So sometimes it's a little bit hard to find that data depending on your source, but it is more, it gives us a real better picture of what is going on in specific populations and where that need is if we can get down to that level. So we really try to dig that out where we can. This is just not all the indicators, but an idea of what we started with. So this would be in the report in some fashion or another. So our buckets that we have them are our domains, our indicator groupings, and then specific ones that we've had throughout with the data attached to and kind of how we compare to the state. Don't try to read it here. I'll forward a slideshow on it. Hopefully when you get the final copy, it'll be there as well. And now to dive into some more specific data. So these are kind of tied to the priority areas that we ended up choosing. So mental health care and access was a big one. And it's probably no surprise to anybody, mental health providers throughout the state, throughout the country. It's very hard to find them. So this is the ratio of residents to mental health care providers in the area, and you can see in Barry County, there's a pretty high ratio. So there's definitely a need there in terms of those providers. Again, with mental health, poor mental health, this comes from our behavioral risk factor survey. I will point out for the second one in the orange, Barry County, there was a wording change that we had tried in 2011 to 2013 that sort of threw people for a loop. It gave us some maybe not so accurate information at that time, and then we had changed it back in 2014 to 2016. So you can kind of see there is a trend upward of people having difficulty with their mental health or saying they have poor mental health, which in this case is defined by more than 14 days in the past month where they've felt they had poor mental health. In terms of substance use disorders, one of the things we looked at was adult binge drinking. So again, here we can see kind of a little bit of a positive trend there, maybe, just depending on how that variation goes. I'm very interested to see in this coming cycle when the 2022 data comes, whether or not that keeps going down or whether or not we go up again, and kind of how that looks, because that will have some things going on during COVID, which will be a very interesting data set to look at, kind of breaking it down in years there if we can, as to what changed and when. But overall, I would say, while it's going down, it's still nice to see it's lower than the state. I am very interested to see where it progresses from here, given all the challenges we know related to COVID. So for adolescents, we have our Michigan Profile on Healthy Youth, our MICI survey. And so we have data going back quite a while for that. And you can see there's a nice downward trend, even though it kind of varies throughout the years again. Unfortunately, they changed the wording on the CDC behavioral risk, the youth risk factor survey that they use for the 2017-2018 survey. So we couldn't really compare those going back, but they are using that going forward, and hopefully when we get that 2022 data, we'll have an even better picture of what it looks like. I do want to bring up kind of a challenge related to this data. We've been told through our different meetings and groups, MyFi data relies on survey of high school students and middle school students. So 7th grade, 9th grade, 11th grade. I've been told by some folks in the community that there's been some skepticism as to whether or not they should fill out the survey. And there's a real concern that this survey data will not come through this cycle either. So it missed last cycle because of the way COVID shook out. They weren't able to complete the surveys in time, and then based on that skepticism, we don't know if we're going to get it again. It is typically done shortly, kind of right around when summer break comes. So hopefully it's there. If it's not, hopefully we can do some work to get people to start filling that out again, because it really does give us good information about what is going on with that age group population, and to really try to get folks to have those healthy behaviors that are really important to set them up going forward. Another one I just wanted to highlight, these are people who do not state they have a healthcare provider that they would consider their primary provider. So again, some positive information within there, kind of a little bit of a downward trend. again, almost every 2 years it seems to vary. The questions haven't really changed all that much, but just based on the responses you get for that year, it can vary. The good news is it's lower than the state, and it does seem like it's trending downwards, especially after things like the ACA and Medicaid expansion in the state. It does seem like people have more primary care providers than they were saying in the past, but there's always those challenges with having providers in the area that they would consider going to in general, being able to access. Switching gears a little bit, we're going to talk kind of about the community engagement piece, so our interviews and surveys and things like that. So this is what we use to kind of paint that whole picture. So we have the hard data, we know what that looks like, but it doesn't capture the right now, it doesn't capture what the people are feeling, so we really want to go out into the community and see and ask those questions. What are the challenges you're seeing? How do you feel like you can access these things? Do you feel like there's a problem? And get that response to kind of paint that whole picture, because sometimes that is more immediate than kind of data that's a year or two old. And so this time around, unfortunately not able to get the focus groups as I had mentioned earlier, but we were able to do 8 interviews thanks to Emily and the United Way folks having them down here and getting us those interviews. So what did we learn from them? So a lot of this was just after the initial phase of COVID. So that's kind of what this reflects, is that there were a lot of issues for people around it. So everything from food shopping, hanging around their family, just being around people in general, accessing things they never thought they would have to access, such as food resources, all challenging. And again, this is all really before vaccines were widely available. So that was an added tough thing. I remember one person specifically said that they really didn't want to be around their grandkids until they knew that their grandkids could be vaccinated. And so it was really hard to hear some of the struggles that people were going through all this, because it just felt, for some people, it just felt like it kept on coming. Accessing healthcare in general, there was both good and bad during this time, so people really spoke highly of having the telehealth visits and being able to access things that way. Obviously, there's challenges in the area still with broadband access, being able to get cell service, those sorts of things which make access difficult, or just people being unwilling to use the technology to do that, especially in probably older populations where they're a little bit more skeptical of technology to begin with. Getting that buy-in from them to be able to do that, and then there's still those barriers for, that's just physical healthcare, well, part of physical healthcare. There's also the dental, the vision care that were also had those same things. So you hear about people not being able to go to their regular doctor, but you don't really hear as much that they didn't want to go to the dentist, they didn't want to go get their eyes checked. And those are all important screenings that should be done, as prescribed by their doctor or their care provider. And then another concern, just lack of specialty care in the area. Again, nothing new, but people saying, most of the time they're going to end up going to Grand Rapids for their specialty care, or sometimes down to Kalamazoo or Battle Creek, just depending on where they live in the county.
Just a comment
yes.
on that, because I think that some of it, we've been trying to get out to Kiwanis and Rotary in different areas, but at Pontiac we have what's called our multi-specialty clinic, and it's kind of like on certain different days, there'll be certain different specialists there, and those doctors are oftentimes actually from Grand Rapids because we don't have the volume. So actually the people who are going to Grand Rapids to see a specialist can see the exact same doctors here. So it's kind of getting that word out and that communication.
Well, that'd be great. No, that would be something that would definitely be something we want to share in our CHIP process. Is that if you want to contribute that to what's out there, that would be something really to get out in front of the public, because that'd be great.
And actually, I brought quite a few in the last couple of years as far as hand or but yeah.
So some more just about kind of the interviews. One really outspoken person about the state of mental health care. They were kind of not happy with how things were. That was only reflected in one interview. Overall, the challenge of accessing is still a concern, despite that. Another one had mentioned that specific outreach to seniors was more important, as they felt like they had friends who felt isolated and didn't feel like people were reaching out to them to alert them to services or things available to them, even through like the Office on Aging, those sorts of things. So they suggested some more additional outreach around that. But generally, that's all the bad stuff, but generally people did speak really highly of living here. They enjoyed kind of the more rural aspect, the small town feel, the natural beauty of the area, being able to go outside during during the nice weather and just go for a walk in the middle of the trees and enjoying it that way. So I don't want to make it sound like it's all bad. There were definitely positive aspects that came up quite often about how they felt about living in the area. And then just one small note, there were people who were interested in, we're in a rural area, so there's farms and everything around. People were really interested in learning how to cook or learning how to cook different things and using those fresh ingredients that can be found locally to help them live a healthier life. In terms of the survey, we had about 400 responses, which is great. I don't remember quite how many we had last cycle, but 400 is an exceptional number to have people respond to a survey. Generally speaking, the access to healthcare and affordable healthcare were the top two things they listed there as what they think when you ask them, what do you think makes a healthy community? Those were the top two. Alcohol, drugs were the top things that affected them negatively, so they felt. But also affordable access to behavioral health, lack of access to healthcare, chronic diseases, and poor access to nutritious food was also tied with mental health problems. Most people, and this is going to be on the healthcare provider side as well, felt that they agreed that addressing social challenges and social needs was just as important as addressing specific healthcare needs. So it's good to see that level of kind of awareness that those things do feed into their health. Most did feel that they had access to healthcare if they needed it, which is good. So they felt like they had an idea of the systems in place that they could access things if they really, really needed it. And they don't really feel like there's many barriers keeping them from that, at least culturally or in terms of language in this area. For the providers, about 30 responses or so. Again, healthcare access, behavioral health access, affordable healthcare were the top three when they were asked what defines a healthy community. Nutritious foods, good jobs, healthy economy rounded out the top five. Calling out the patient's lack of motivation to make health-conscious decisions, probably a provider favorite. I think that one's probably been around for quite a while. Low household income, they felt they were seeing people who maybe didn't feel like what the providers were seeing, didn't feel like those patients had the resources they needed in terms of income to get what they needed to stay healthy. Lack of access to insurance, high-cost medications, and then just general education about making those decisions. So not just the motivation to, but really the education behind making those decisions also popped through in the survey. In terms of referrals, they often were referring folks to the CMH services and home care hospice. Again, they agreed with the social needs being just as important. They do feel that unmet needs for their patients often prevent them from, achieving higher quality care because they feel like they're not able to address everything themselves, and so seeing not getting those other pieces is keeping them from really kind of making them get that quality care that they feel they need. And again, most in the survey did not feel like there were any cultural or language barriers. For our county leadership, call it a summit, but meeting, there was a feeling that overall healthcare providers were scarce, not probably a surprise, but particularly mental and behavioral healthcare providers, which we saw on our data piece earlier. The availability of safe and affordable housing is pretty low, and some comments as to folks wanting to sell and get out of the housing market in general, just due to how crazy everything was. Low stock, those sorts of things, people wanting to sell their homes or the apartments they were working with just to be done with it. There were individual families in areas that still don't have broadband access. I do know that's something that's underway and being worked on. So hopefully at some point in the near future that will be addressed. But until then, still definitely an area that felt like it was a big need. And although, again, this group also felt that although there are some resources that are limited, it is there for those folks who need it to get what they need in the end. So just a visual kind of representation of what I just mentioned, the pressing needs of the health community, just a quick visual. Our asset map, so this is what we talked about in terms of economic resources. So this was what folks wanted to see mapped out in terms of what was available to them. Really the focus was sort of on we had said, these are the things we usually look at. So, physical health, behavioral health, food resources. And then we had a discussion with the group, and they decided economic resources. We want to see what's out there. So with the focus on this, this is what our map ended up looking like thanks to the Barry GIS folks. So large employers, so places people are going to go to find jobs, places to get some upskilling, so like things like and job placement services, so Michigan Works, training centers, libraries, those sorts of things. That the idea was that like if somebody either loses a job or is looking to move to the area, those things where they go, I can get a job at this place, or these are where I can go look to to be able to make myself feel comfortable living in the county with the resources we have. The next big meeting we had was the data previews. This is where we took all the data kind of that I previewed before, showed it to the community and got feedback. And this was, again, we had some new measures, which had never happened before. That's kind of great. And these are them. So we had originally just been looking at smoking, but people wanted to see kind of, e-cigarettes, vaping as a thing as well. And so we included that. And in the future, I think we're going to be doing just like nicotine overall, so finding a way to combine those two together instead of having them side by side. And so you can see, these are folks from our behavioral risk factor survey for adults who had said that they had used on some days or most days in the last month e-cigarettes or vaping products. Just an absolutely huge increase. And again, on the adolescent side as well, that is data we would lose should we not have responses to the MiFi survey. Felt like marijuana use was also a thing we should look at. Again, this also applies to MiFi, so it's both adult and adolescent youth use, or this is specifically adolescents. So we can see on the rise there, current 30-day use saying that yes, in the last 30 days I have used this. So an increasing trend there, not just in Barry County, but across the state as well. Use before the age of 13, interestingly going lower as opposed to current use, while in the state it is increasing. So very interesting. But again, this is the adolescent data, so we will lose out on this if we don't get the responses. After that was prioritization, so we took the data, we've got it all, we've analyzed it, we showed it to everybody, and now we say to everybody who came to the meeting, what do we think is the most important? So we came up with a scheme to kind of weight it and rank it, and then everybody had a series of votes. And those 4 votes were on 4 different areas, so seriousness, or how much does this actually impact health directly? Control, how much do we as a community actually have the ability to control it? Like, is this a state law that we can't touch? Is this something that comes from somewhere else that we have no influence on? Or is it something that we can change? Capacity, so specific resources inside our community, like do we have the specific resources and availability to do something about it? And then catalytic, which is just how it impacts all the other areas that you're looking at, all the other measures. These are our categories. I'm not going to rank them out. There's a lot of different ones that cover a lot of different areas, and they all have individual indicators tied into them to make them like larger groups that are more representative kind of that area. And so in the end, we chose mental health needs and access, affordable housing, healthcare access and quality, and substance misuse as our 4 priorities. And that's kind of where we're at now. So kind of what comes after this. So after we have our assessment, we publish our report, we move on to our CHIP, so our Community Health Improvement Plan. And we use this as a tool that's going to describe our vision, our goals, our objectives, and the activities we're going to do with the different partners in the community to address those priorities. Where we can, we want them to be backed up by evidence-based research. We want them to be, through a rigorous assessment, which is not just throwing things together to say we have something, but really having that process in place to make sure we have a systematic improvement. We want it to be collaborative, so we want it to be all different sectors coming together to address these things, and not just healthcare access, healthcare access folks doing healthcare things. There are lots of cross-linkages that can happen to different organizations. We want to find those and we want to use those to our benefit where we can. And then it is, for us, a requirement for FAB, but less important than getting those other community linkages because it's impacting the health of the population we care about more than just being a requirement for an accreditation board. So some essential things to keep in mind when we move into this. We do want to have ongoing communication between all the parties we can. So obviously we're going to keep continuing to work with Spectrum. We want to tie in all the other groups that we can in the area that we've worked with so far and expand that beyond what we have. Because there are lots of even small groups that often don't get thought of that can do good work and that we can get involved and have an impact where maybe they thought they couldn't previously. And then we want to share the results of what we're doing. We want to keep it out there, show the public what we're doing, and stay accountable that way as well, and make sure that we are getting that out there to say what we're doing. Again, we're going to, after we publish, kind of what we're looking forward to here is after we publish the CHA, the report, we will move into our CHIP. So I'm hoping to finish it sometime around July, just to get that out there and done, and then we can move into that phase. We're going to gather our groups together on the selected priorities, so we have the list of people who participated already. We'll start by probably reaching out to them, getting an idea of who else we should tie in, start those conversations, and then move into doing our goals and objectives. So even though I have like a compilation of ongoing efforts here, that's only part of it. We really want it to be an all-inclusive process to keep you, have ongoing conversations, ongoing communications, ongoing working together, to have those linkages to make sure that nobody just kind of sits back after the assessment is done. Because a lot of times in the past, that's what's happened. It's harder to keep the CHIP together and moving forward because there's so many different people involved. There's so much time involved in doing these things that sometimes you feel like you want to give people space to do it and work on it, but then they end up doing other things because there are also other pressing matters to go on and work on. But to really keep those things that's cited as priorities going forward, we want that to be part of it as well. So just some examples of what you can use it for. There's a lot up here, but you can use it for grants, you can use it for educational purposes, you can use it if you're writing something to add different perspectives based on the populations you call out. You can use it for dashboards, you can use it to address urban versus rural issues if that's the thing where you're working. All sorts of different things. Reporting requirements, always important. So when it's out there, feel free to use it for whatever you need it for. And that ties into the last one, is just kind of tell us what you're doing with it so that we have an idea of what we can do with it next time based on what you're using it for. So it's not just us coming and saying, here's the data, but we want to hear what you're doing with it, and that can give us an idea of how to use it better going forward. And then if you aren't already addressing a priority that was chosen, please consider doing so. Reach out to a group if you think they're going to do work on it. Reach out to us to say, I don't know who could be working on this, and then we can try to make that connection for you as well. And then that's kind of the end of it, so ways to connect with it. Our website is managed by Emily, so thank you for that. If you want to be added to an email list or just generally know what's going on, that is my contact information up there. And I'm going to leave it there for questions and ask Emily if you want to come up to help answer some questions if there are any. Or just general discussion about it, anything like that.
Emily, did you have anything you wanted to add?
Chris, I think you did a great job. We always talk about I'm kind of the people-facing person, and Chris is the data person, and we work as a team really well. I think you did great. And it's a great project. We do it in both of our counties, and it's really helpful moving forward to understand what the problems the community is facing, but also how can we work together to address those.